the small group discussion immediately after the BGD?
Same, me also, Dr. Wong, from Gutierrez to Incheon. So after the two BGDs, we'll proceed with the SGD.
Me three, Dr. Ismail's group.
I think we can start, Dr. Chan.
Yes, yes.
Is Aliyah? Aliyah, I think you may start.
Okay. Okay. Good morning, doctors. We are subsect B1, and we are here to report the first BED, which is about upper gastrointestinal tract. For so, for our case, we have a 65-year-old female with a chief complaint of melena or the passage of black tarry stools. For her history of present illness, 6 months prior to admission, she experienced vague epigastric discomfort. However, no consultation was done and no medication was taken. 2 days prior to admission, she experienced 2 episodes of melena, amounting to 2 cupfuls per episode, and 1 episode of coffee ground vomiting, accompanied by cold, clammy sweats and dizziness, which led to her admission to the ER. For her medical history, she is hypertensive and diabetic for 15 years, and she takes losartan, clopidogrel, racetin, and metformin. 5 years ago, she was diagnosed with osteoarthritis, and she takes diclofenac sodium intermittently, and her last intake was 1 week prior to admission. She experienced 3 weight loss for the past 6 months. For her physical examination, she has postural hypertension, tachycard- tachycardic and and according to her height and weight, she has a BMI of 26.5, which classifies her as obese class 1 to according to the Asia
Aliyah,
Pacific standards.
do you,
Yes,
do
doc.
you have salient features? Like,
Yes,
have
doc.
a slide on. Maybe we proceed to that because the history and P are already, everybody has read about it already. So just summarize it using the salient features.
Yes, doc. For the
So
summary
yeah,
of the salient features, for the subjective findings, we have a 63-year-old female who experienced vague epigastric discomfort, 2 episodes of malaria, 1 episode of coffee ground, and accompanied by cold lumps, clammy sweats, and dizziness. She's hypertensive, diabetic, and has osteoarthritis, and she has a significant weight loss. She is positive for NSAID intake and antiplatelet drug intake, and at present, she has fibrillary abdominal pain. For the objective findings, again, she has postural hypotension, tachycardia, and tachypnea. Her BMI is 26.5, which classifies her as obese class 1 according to the Asia Pacific standard. She has palpebral conjunctiva. Her apex speed is at the 6th intercostal space. She has hyperactive bowel sounds uh, and her digital rectal exam, she shows maroon colored stools.
John Emmanuel A. Corpus. Good morning, doctors. I'll be presenting about the general approach to patient presenting with upper GI bleeding. So I divided the slides into three for the initial assessment, differentiation of upper GI bleeding from lower GI bleeding, and evaluation and management. So first, for the initial assessment, it is important to measure the heart rate and blood pressure because it is the best way to initially assess a patient with GI bleeding. This is because in cases of severe blood loss, the goal would be to stabilize the patient as soon as possible. This can be done by measuring their heart rate and blood pressure. So clinically significant bleeding would present with postural changes in heart rate or blood pressure, tachycardia, and recumbent hypotension. Those in bold are the ones present in our patient. Then for the hemoglobin, it is not really reliable initial assessment of GI bleeding because hemoglobin may be normal or only minimally decreased at the initial presentation. This is because when the patient bleed, they bleed whole blood, which means that there's a proportionate reduction in plasma and red blood cell volume. Therefore, hemoglobin may be normal or minimally decreased and would only decrease by 72 hours. Then it is important to differentiate acute GI bleeding from chronic because it presents differently. So for GI bleeding, high heart rate, low BP, and normal hemoglobin. On the other hand, chronic GI bleeding presents with normal heart rate and BP with low hemoglobin. So next, it is important to differentiate upper GI bleeding from lower GI bleeding to further pinpoint the source of gastrointestinal bleeding. So upper gastrointestinal bleeding presents with the following. First is hematemesis, which is the vomitus of red blood or coffee ground material. Another is melena, which is characterized by black tarry stool in appearance and results from degradation of blood to hematine or other hemochromes. So it presents when the blood is present in the GI tract for at least 14 hours to 3 to 5 days. And the more proximal the bleeding is, the more likely that something will occur. And other clues for upper GI bleeding is hyperactive bowel sounds due to blood in the proximal gut and elevated blood urea nitrogen and nasogastric aspirate. Then for the lower GI bleeding, it could present with hematochezia. However, hematochezia could also present with upper GI bleeding when the upper GI bleeding is very brisk, that the blood transits the bowel before the melena develops.
John,
Yes, doc.
sorry, you mentioned that hematochezia can be seen also among patients with upper GI bleeding. How about melena? Can patients with lower GI bleeding present with melena?
I think no, doc, because when when the when the bleeding is in the lower GI tract, is in the lower part of the gastrointestinal tract, there would be lesser chance for the blood to form melena, doc.
Yes, but yeah, you may be correct, John. But the transit time is also important. You mentioned about 6 hours, 8 hours, 14 hours. How many hours the blood stays there. But if the transit time is long, then
Yes, doc.
even lower GA bleeding may present with melena.
Okay, doc. Noted.
Okay, continue, John. Continue.
So next is for
So,
the
Dr. Ruiz, are you going to say something?
Yeah, John.
yes,
Therefore, in this particular case, if you will insist that this patient has upper GI bleeding, what is the one single most important evidence that the patient has upper GI bleeding?
hmm,
What she's referring to, John, this is Dr. Ismail. In your upper GI bleeding chart, you have those five manifestations. So which among these is will really tell you that it's upper GI?
it could be the hematemesis, doc.
Okay,
Okay.
okay.
Yes, doc.
So just to emphasize, no, because a while ago, Dr. D was saying hematochezia and melena can occur in both upper and lower GI bleeding. Okay.
Thank you, doc. So next is for the evaluation and management. So baseline characteristics may be used to predict the occurrence of rebleeding and death. So these characteristics are hemodynamic instability or tachycardia and low BP, then increasing age and comorbidities. Then you can see at the right side of this PowerPoint is the Glasgow Plus 4 chart score. So risk assessment tools such as this may be used to evaluate whether the patient is at very low risk of complication. So this risk assessment tool uses BUN, hemoglobin, systolic BP, heart rate, and markers for comorbidities to identify a patient's level of risk. So actually, this Glasgow Blatchford score has a total score of 23, and if a patient scores 0 to 1 or 0 to 2 among patients that are younger than 70, discharge from the ER with outpatient management may be suggested. Then lastly, we have here the suggested algorithm for patients with acute upper GI bleeding based on endoscopic findings. So with the presentation, we could note that PBI infusion may be considered as it decreases high-risk ulcer stigmatas, active bleeding, the need for endoscopic therapy. However, it is important to note that it does not improve clinical outcomes such as further bleeding, surgery, and death. Then to dissect this algorithm, we divided the algorithm into two. The ones in red boxes are the ones that has high risk endoscopic. The ones in green are the low risk. So first, for the high risk endoscopic findings, it is important to note that this, such as varices, ulcers with active bleeding, visible vessel, and deer clot, benefit from endoscopic hemostatic therapy. On the other hand, the low risk patients, such as flat pigmented spot ulcer, ulcer with clean base, microvascular tear with no active bleeding and erosions does not benefit from endoscopic therapy. So to further dissect this, uh, the ones in red boxes all benefit from endoscopic therapy. Then the ulcer with active bleeding or visible vessel and adherent clot has very much the same management. So for the medical therapy, they both require intensive API therapy. Then diet, they require clear liquids for approximately 2 days. And for the hospital stay, they're both hospitalized for approximately 3 days. The next is the esophageal varices. So the difference here is for the endoscopic therapy, it requires endoscopic ligation. Then for the medical therapy, because it has a very high chance of bleeding, it requires vasoactive drugs such as octreotide. Then for the diet, it also requires clear liquids for approximately 2 days. Then on the other hand, revised there with active bleeding, it also requires endoscopic therapy. And since the pathophysiology of malarialized there includes vomiting, medical therapy requires antiemetics for ongoing nausea. Then for diet, it only requires clear liquids for approximately 1 day and hospitalization for a shorter period of time, which is approximately 1 to 2 days. Then for the low risk patients, three of them have the same, almost the same management. Also with clean base, no active bleeding, malarialized tear, and erosions. All of them does not require endoscopic therapy. All of them, uh, both malarialized tear with no active bleeding and erosions does not need endoscopic therapy. And for the medical therapy, erosions require
Excuse me,
1 to
Dr. D?
Yes, John, this is kind of specific what you are presenting. I will want you to just give us an approach. So these are already specific diseases wherein we treat using these modalities, which will be discussed later. So how do
yes,
you approach a patient with GI bleeding? When a patient comes into you at the emergency room, what do you do? You mentioned about Glasgow Blatchford score, but in the emergency room, what do you do? How do you determine whether this is upper GI, this is lower GI? What do you do?
use ano doc, endoscopy doc, to determine if it is upper or lower GI bleeding.
Well, there's a algorithm in your horizon that tells you the general approach of a patient. You look at whether there's patients with hemodynamic instability. If there is, then you rule out upper GI. If there isn't, then you think of upper GI diseases, then so on and so forth. Um, this is kind of specific. Uh, this will be discussed later by the next presenter.
Yes, ma'am.
The next,
Can we move on?
Okay.
Good morning, doctors. I am Cortez Kimberly Rose, here to present the differential diagnosis for our patient. So, based on the clinical presentation of the patient, which are melena, hematochezia, and hyperactive bowel sounds, we can deduce that the patient has upper GI bleeding. Um, So gastrointestinal bleeding can be further categorized based on its location, wherein upper GI has um, upper GI bleeding happens around the esophagus, stomach, and duodenum, where GI bleeding is located at the intestines, and it is called obscure GI bleeding when there is unclear source of the bleed. So here are the most common differential diagnosis for upper GI bleeding. So we can the ones in the blue, bold text are those that we consider for our patient, considering the patient's clinical presentation and risk factor profile on the right. So first is peptic ulcer disease. We can rule this in based on the presentation, as well as the NSAID-induced gastropathy based on the past medical history of the patient, wherein the patient has a chronic intake of NSAIDs. Furthermore, we can also rule in gastric carcinoma based on some of the presentations of the patient. We ruled out the other common differential diagnosis for upper GI bleeding, such as Mallory-Weiss tears, since there were no history of alcohol intake from the patient and no vomiting preceding hematemesis. Esophageal varices was also ruled out since there was no history of advanced liver disease by the patient.
Wait, Kimberly,
Yes, doc.
Dr. Ismail.
Yes.
In your differential diagnosis, you place NSAID-induced gastropathy in erosive disease. Let me just tell you that NSAID can cause erosions as well as peptic ulcer. Okay, when you say erosion, these are shallow defect in the mucosa. It doesn't go beyond the muscularis mucosa. But when you have peptic ulcer disease, that's deeper. Now,
Okay.
NSAIDs can produce lesions that range from erosions to peptic ulcer. Okay, so I just don't want your classmates to have that idea or impression that NSAID-induced gastropathy only causes erosive disease. Okay,
Yes,
that's
doctor.
just a clarification.
Okay. Thank you, doc.
And also,
Okay.
Kimberly,
Yes,
Kim,
po.
you
Yes, po.
mentioned a while ago that you were not thinking of Mallory Wise because the patient is not um, alcoholic, has not any intake. It doesn't have to be the patient is taking alcohol. Just as long as the patient has history of retching before GI bleeding, then you consider Mallory Wise. You don't have to have an alcohol intake.
Okay, po. Yes, doc.
Okay, continue.
Go ahead, Christian.
I don't hear anything. Do you guys hear anything?
Me too, I don't hear anything.
Baka
Yeah,
naka-off yung microphone
Christian,
ni Christian.
are you
Can you check your
having
microphone, Christian?
difficulty?
Christian, lumayo-layo ka sa mga manok, Christian.
Hello, Christian.
Christian, the microphone button is
No,
at the bottom.
Hindi, baka nagkakape siya eh.
Oh, get inside
Christian,
the house. Don't stay in the poultry house.
Christian, can you message us first if you're there, if you're ready or what?
Nag-advance yung slide niya, so I think he might be there.
Hindi pa, one pa lang.
my
No.
slide is still
Earlier,
Kimberly's.
earlier his mic was on, but now it's not.
Ah, okay.
Baka mag-reconnect na.
My slide is still Kimberly's. Am I
Reconnect.
supposed to?
There, I can see your mic on, Christian.
Hello? What's
Obe,
happening?
who's the fussy? Who's the fussy of the first group? Maybe we can call him up.
Dr. Chan po.
Nagkakaproblema siya. Look at the message. John Hermoso is trying to give some instructions.
Yeah, I agree with Dr. Velasco. Can
Yeah.
we move on to the NSAID group first, and then we go back to this group so that we can proceed with our discussion, if it's okay with everyone?
Yes. Is the NSAID group ready?
Yes po, Doc.
Agree.
Yep.
Agree.
Okay po.
Oh, ayan na si Christian, no? Okay. Okay.
So, good morning, everyone. So,
Good
here
morning.
is, we will be reporting about NSAID gastropathy. So, let us first tackle what is NSAID gastropathy.
Ivy, can you reduce your volume? It's
Okay. Hello. Ito po. So, NSAID gastropathy is generally characterized by some epithelial hemorrhages, erosions, and ulcers. So this is an image shown in order for you to visualize what are erosions typical of NSAID use. So next is that NSAIDs are also known as non-steroidal anti-inflammatory drugs, which primarily work by inhibiting the cyclooxygenase enzymes COX-1 and COX-2, which is the rate-limiting step for prostaglandin synthesis. And so NSAID gastropathy happens because there's impairment in the prostaglandin synthesis brought by either high dosage, long-term use, or frequent intake of NSAIDs, thus promoting mucosal injury. This will be further elaborated by Dr. Quaresma later. So the etiology based from our reference book Harrison's, NSAIDs is the most commonly used drugs, and its adverse reactions are most common drug-related toxicity in the U.S. So NSAID-induced morbidity spectrum ranges from nausea and dyspepsia to a more serious GI complications such as documented peptic ulceration. So approximately 60,000 are admitted to hospitals annually due to NSAID-induced GI bleeding, and as high as 16,000 are documented to die from NSAID-induced toxicity, while around 4 to 5 only develop symptomatic ulcers within a year. So there is no dosage of NSAID completely safe since low dosage of aspirin may cause mucosal injury to at least 8% already. So a combination of intake of alcohol with NSAID is said to increase the risk of gastric mucosal damage and
Christian, sumisingit ka eh.
so as what I was saying a while ago, a combination of intake of alcohol with NSAID is said to increase the risk of gastric mucosal damage, and chronic ulcers of low dose aspirin also increases the risk for PUD associated GI bleeding with the presence of H. pylori infection. So just additional information, a study done by Agustanti et al., wherein they examined 7,554 patients who were referred for upper endoscopy. They found out that most commonly used NSAID is aspirin, around 33%, wherein diclofenac was the least used, wherein the symptoms of NSAID-induced gastropathy mostly comprise of epigastric pain, and majority of the endoscopic findings are erosions. So for the pathophysiology, Dr. Quaresma will be um, explaining.
Dr. Ruiz. Okay, Dr. Quaresma, I think you can proceed.
Okay, good morning, doctors. I'm Bianca Quaresma, and I'm
Hey,
going to
Ome,
present.
excuse me, sorry. My microphone was mute pala. Sorry. Can you go, Ivy, can you go back to the previous slide? Okay, this is just to look, guys, look at the source. It is the section of gastroenterology. It is our section. This was one of the papers led by Dr. Soliano, one of our staff, and two fellows at that time. Okay, so this is a publication by the section. And Ivy, that was a very good presentation. That's
Thank
all.
you, Doc.
Okay, so good morning, doctors. I'm Bianca Quaresma, and I'm going to present the pathophysiology of NSAID gastropathy and its clinical features and risk factors. So prostaglandins is one component of the gastric mucosa that is present in abundant levels, which play a central role in gastric epithelial defense and repair.
Its functions are to regulate release of mucosal bicarbonate and mucus, inhibit parietal cell secretion of acid, and maintain mucosal blood flow as well as stimulate epithelial cell restitution. They are derived from esterified arachidonic acid, which was formed from phospholipids in the cell membrane by the action of phospholipase A2, a key enzyme that controls the rate-limiting step in prostaglandin synthesis is glycooxygenase, or COX, which is present in two isoforms, COX-1 and COX-2. Of interest here is COX-1, which is expressed in a constitutive manner in the stomach, kidneys, platelets, and endothelial cells. It plays an important role in maintaining the integrity of the GI mucosa, among others such as platelet aggregation and renal function. On the other hand, COX-2 is inducible by inflammatory stimuli, and it is expressed in macrophages, leukocytes, fibroblasts, and synovial cells. The beneficial effects of NSAIDs are due to the inhibition of COX-2. However, its toxicity mainly concerns the inhibition of COX-1, resulting in the reduction of prostaglandin synthesis, leading to a reduction in mucosal blood flow, hypoxia, and a reduction in mucosal defense. That being said, one mechanism of NSAID-induced GI injury would be an interruption of the prostaglandin synthesis, which can impair mucosal defense and repair. Another one is through direct toxicity, wherein topical encounter with NSAIDs results in epithelial surface permeability. Aspirin and many NSAIDs are weak acids that remain in a non-ionized lipophilic form when found in the acidic environment of the stomach. And under these conditions, a phenomenon called ion happens wherein NSAIDs migrate across lipid membranes of epithelial cells, leading to mucosal injury once trapped intracellularly in an ionized form. Topical NSAIDs can also alter the surface mucous layer, permitting back diffusion of hydrogen ions and pepsin, leading to further epithelial cell damage. And for the leukotriene-mediated mechanism, it is said that the inhibition of COX may lead to a shunt of the arachidonic metabolism towards the leukotriene pathway. And leukotrienes cause the inflammation and tissue ischemia, leading to gastric mucosal injury. Along with this, there is also enhanced productions of pro-inflammatory mediators such as tumor necrosis factors, which further leads to occlusion of the gastric microvessels, leading to reduced gastric blood flow and release of oxygen-derived free radicals, which consequently react with polyunsaturated fatty acids of the mucosa, leading to lipid peroxidation and tissue damage. So for the clinical features, autoabdominal pain is a common presentation to many GI disorders, including duodenal ulcer and peptic ulcer. It has a poor predictive value for either the presence of duodenal ulcer or gastric ulcer. And it is said that the elderly, which is applicable to our patient, are less likely to have abdominal pain as a manifestation and may instead to present with a complications such as ulcer bleeding or perforation. And in addition, up to 87% of patients with NSAID-induced mucosal disease can present with a complication such as bleeding, which is the most common, perforation, and obstruction without antecedent symptoms. And for the established risk factors of NSAID gastropathy are the following. Advanced age, which since the elderly is a
Dr.
group
D, you
commonly
have a question?
associated
I'm
to have
sorry.
high NSAID use, and regular use of NSAID increases the odds of GI bleeding 5 to 6-fold compared with persons not taking NSAIDs. History of ulcer, concomitant use of glucocorticoids, anticoagulants, or clopidogrel, and serious or multi-system disease. While for the possible risk factors considered are concomitant infection with H. pylori, which is said to have increased the risk of peptic ulcer disease associated
Bianca.
GI bleeding in chronic users of low-dose aspirin, as well as
Bianca.
cigarette smoking and alcohol
Yeah, yeah.
consumption. Yes, Doc.
Dr. Quaresma, I would like to interrupt you a little while. This is Dr. Chan. You have to specifically mention that these risk factors that you're mentioning are risk factors for complications of NSAID-induced gastropathy. These are not risk factors for NSAID-induced gastropathy. They are clearly just risk factors for the occurrence of complications associated with chronic intake of NSAIDs. That, I think, is important to remember.
Okay. Yes, okay, Doc. Thanks. Thanks, Doc.
Bianca,
Yes, Doc.
why do you think patients who are taking NSAID, they tend to be asymptomatic and then they develop complication? Diba you mentioned that elderly, especially elderly individuals, they just come in because of complication. Why do you think this happens?
There is due to the usage of NSAIDs, there is uh, masking. The symptoms are masked.
Because why are the symptoms you are mentioning specifically is abdominal pain, right? So the abdominal pain is masked if the patient is taking NSAID. Why? You have any idea, Bianca? Oh, let me answer that para mabilis tayo. Because, NSAID has anti-inflammatory effect, di ba? That's the reason why when you take NSAID, it's also given for patients having pain. So abdominal pain is not different from any other forms of pain. Like if you're giving NSAID for arthritis, you also give that to reduce or to relieve the patient's pain. So if your patient is taking NSAID, abdominal pain probably will not occur. Tama?
Yeah. Yes, Doc.
Okay, so can we move on?
We need to move on, Bianca. Who's after you?
John Kenneth po ba? Yes, Doc.
Okay,
Thank you
good
very
morning,
much,
doctors.
Bianca.
Okay,
Good
Jan.
morning. Okay. Good morning, doctors. I am John Kenneth Vicubalias, and I'm going to present the diagnosis and treatment for NSAID gastropathy. As for the diagnosis, um, we should have a good history, and we should ask the patient if the patient has a history of long-term NSAID intake, and if the patient has several conditions wherein NSAIDs are warranted, such as those with cardiovascular diseases like coronary heart disease, and also for those patients who have recent injury or wherein NSAIDs are warranted due to the pain. And also, we should exclude H. pylori infection since H. pylori may also present um, ulcerations similar to that of NSAID gastropathy. And also, we should screen for aspirin or NSAIDs in the serum or in the urine since we may detect patients who are using aspirin through this screening tests. Also, we can document an
Before you go
ulcer.
any further, excuse me, Dr. Cabales. before you go any further, I would just to correct at this point in time, because aspirin or NSAID in the blood or urine is not used in clinical practice to make a diagnosis of NSAID-induced gastropathy. It is only the history which is really very helpful in making the diagnosis. When you say
Yes po.
long-term NSAID intake, how are you referring to? Is it 1 day, 2 days, 3 days?
John, are you still there?
Yes po, Doc.
John, what do you mean by long-term NSAID intake? Let's qualify this, because taking it for 2 days does not probably expose you to the risk of NSAID-induced
Yes po,
gastropathy.
Doc.
Yes.
Long-term NSAID intake po is when the patient is taking it, the NSAID such as aspirin, for their maintenance, such
So
as
it's
if
more
the
than two
patient
weeks.
has
It's more than 2 weeks,
stroke.
John.
Yes po,
If
Doc.
you're
Yes
taking
po, Doc.
NSAID for 2 weeks, more than 2 weeks, that's considered to be already a chronic intake of NSAID. And
Yes po,
like I
Doc.
said, please forget about the blood or urine aspirin or NSAIDs, because this is not done. It's rarely done or not done in order to make the diagnosis of NSAID gastropathy.
Noted po, Doc. Noted.
Oh,
Thank you po,
last,
Doc.
Okay, another thing, Jan, this is Dr. Ruiz. You mentioned exclusion of H. pylori infection. We need to put that into context because you mentioned H. pylori as a possible cause of peptic ulcer disease. Please take note that the two can occur together, okay? So the context there of H. pylori is if you have, for example, an NSAID-induced ulcer, you should try to see whether H. pylori is present or not, because H. pylori can increase, okay, the probability for complication. And it has to be treated or eradicated while at the same time taking out NSAID and treating or making the ulcer heal. Okay, so that's the context of H. pylori infection in NSAID-induced gastropathy.
Yes po, Doc. Thank you.
And John, this is Dr. D. While you mentioned that long-term NSAID intake has been associated with the development of NSAID-induced gastropathy, also remember that not all patients who are on long-term will develop this. And number two, you have to remember that even short-term NSAID intake may produce NSAID-induced gastropathy in the right clinical scenario.
Yes po, Doc.
Okay, continue.
So we can document an ulcer through these studies. So we can do a barium study. However, in barium studies, it cannot detect small ulcers that are about 0.5 centimeters in size. So that's why we should also do endoscopy since it is more specific and sensitive, and it can visualize the mucosa and have a photographic documentation of the gastrointestinal tract, and it can also see smaller lesions not seen in radiographic studies such as barium studies. And we can also do biopsy using endoscopy to rule out malignancies.
John, I'm sorry to interrupt you, but before you go any further, if you take the diagnosis in relation to the case that we are discussing, I would like to tell you that radiography is never used in patients with upper GI bleeding. We're talking about upper GI bleeding, and you have to understand that this procedure is never done in patients with this problem. So it might be done for other reasons, but not for upper GI bleeding. So if you want to document upper GI bleeding, it is usually endoscopy or some other test, but not radiography.
Yes po, Doc. Yes.
And also, John, regarding your second bullet point, exclusion of H. pylori infection, you have to note that even patients with H. pylori infection can also have NSAID gastropathy along with H. pylori infection. So they sometimes are synergistic in producing the lesion.
Yes po, Doc. Thank you po.
Okay.
So for the treatment, for the goals of treatment, we should remove the aggravating agent, which are the NSAIDs, and also the treatment of the active ulcer, which we can also do primary prevention to prevent future injuries. So for the primary prevention, we should avoid the agents, and also we should use the lowest possible dose for the shortest period of time of NSAIDs. And we should also use NSAIDs that are theoretically less injurious, like naproxen and ibuprofen, since these NSAIDs are non-selective COX inhibitors. And we should also use newer topical NSAID preparations, such as diclofenac gel and ibuprofen topical preparations. And we may
John,
use concomitant.
John, sorry
Yes, po.
So can you go back to your third bullet point? Sabi mo, these NSAIDs are non-selective, why they are less injurious?
Yes, po, Doc.
So you mean non-selective NSAIDs are better than, let's say, selective NSAIDs? What do you mean? Kasi kung may non-selective ka, meron kang selective. What are the selective NSAIDs? What are you selecting?
They select po a specific COX. For example po,
Okay,
aspirin. It's
so
more
let's say, what COX receptors are there?
COX1, COX1 and COX2 po,
COX1
Doc.
and okay.
COX2.
So
So for
COX1 is for what? COX2 is for what?
COX1 po is for the production of prostaglandins po that are protective to the
Okay.
mucosal
Constitutional.
lining of the gastrointestinal tract.
All right. And then COX2 is for what? What is the function of the if COX1 is constitutional for synthesis and normal functions of the cell, what about COX2?
COX2 po is for the inflammation and pain.
For inflammation and pain.
Yes po.
So if you're taking NSAIDs, for example, for pain, you need to block the you need the COX1 or COX2 to be selected.
It's more of the COX2 po, Doc.
COX2. So are there drugs that are COX2 selective? Kasi yun yung basically yun
Yes po,
yung
Doc.
So what are those drugs?
There are selective
For example?
COX2 inhibitors like they are called coxibs po, like celecoxib, etoricoxib,
Okay.
meloxicam po.
Yeah. So that's why your third bullet point, I'm a little bit confused. Kasi sabi mo theoretically less injurious. Maybe this is for among the COX non-selected. Tama ba?
Yes po, Doc. Yes po, Doc. The
Kasi if you're going
non-selective
to
COX
say,
inhibitors.
if you're going to say which are you going to prefer that is less injurious to the GI tract, will it be the non-selective or the selective COX-2 selective inhibitors?
The selective
Less
COX-2 po
injurious.
are less injurious since they bind to COX-2, which
So
is
kasi yung sentence mo, kung
for inflammation
theoretically
and
less
pain.
injurious, dapat COX-2 specific inhibitors. But among among the non-selective inhibitors, naproxen and ibuprofen will be theoretically,
Less
less
injurious po.
injurious. Okay. Just wanted that to be clear.
Yes po, Doc.
Sige, John. Proceed.
So in the treatment of active ulcer, it is recommended to discontinue the NSAID
Sorry,
to
John.
avoid further injury.
John,
And we could
John, sorry. Sorry to interrupt you. You're supposed to go to treatment for NSAID-induced GI bleeding.
yes po, Doc.
Derek.
Yes,
the
Dr. M.
Dr. D, in their syllabus, this is the only time kasi that they're going to discuss NSAID gastropathy. So they can go through the entire process and then focus on GI bleeding. Because,
Okay,
right?
that would be all
Uh,
right.
Yes po.
yeah, because that's why they have pathophysiology,
Okay,
all
okay.
the other uh, needed information for NSAID gastropathy other than upper GI bleeding, and then focus on upper GI bleed. So they can go on with this.
Okay.
Oh, go on, Jan.
Yes po. So in the treatment of active ulcer, it is recommended to discontinue the NSAID to avoid further injury and to administer an acid inhibitory agent like histamine 2 receptor antagonist or proton pump inhibitors. And if cessation of NSAID is not possible, giving of PPI is recommended to use, for it can heal gastric ulcer and duodenal ulcer even with or without the presence of NSAIDs. And for prophylaxis, we can give misoprostol, which is a prostaglandin, a synthetic prostaglandin, and we can also give PPIs and also selective COX-2 inhibitors. However, we should be cautious in using selective COX-2 inhibitors since there is a cardiovascular risk with their use. And also, as mentioned earlier, H. pylori infection, we should be also cautious for the detection of H. pylori infections since that it may affect the treatment po.
Not cautious probably, Jan. H. pylori infection should be detected, no?
Should be
Because
detected po.
yeah, because actually, as is presented, it can affect treatment.
Okay,
Next.
last slide.
So as for the guide to NSAID therapy, it is divided for those with cardiovascular risk or those who do not use aspirin, and for those who use aspirin with cardiovascular risk. So for patients with no
Can you
cardiovascular
move
risk
your slide,
or
please?
does not take
Next
aspirin,
slide. Next slide.
Next slide, please.
okay.
Click your slide.
Okay.
Okay.
So for patients with no cardiovascular risk or does not take aspirin and has no or low NSAID GI risk, a traditional NSAID like naproxen may be used for it has lower side effects than the usual NSAIDs. And for the ones who has no cardiovascular risk or those who do not use aspirin but has NSAID GI risk, a combination of the Coxiv or traditional NSAID and PPA is recommended to prevent GI injury, and also one should consider non-NSAID therapy. And for those with cardiovascular risk, those who use aspirin and has no GI risk, we can give traditional NSAID plus PPI or misoprostol if GI risk warrants gastroprotection. And we should also consider non-NSAID therapy. And for those patients with cardiovascular risk and with NSAID GI risk, a gastroprotective agent must be needed if a traditional NSAID is prescribed. And we should also consider non-NSAID therapy. So the examples of gastroprotective agents po are like the gastroprotective containing combination pills like double dose famotidine with ibuprofen. So uh, there is in there is a combination of a histamine 2 receptor antagonist and in an NSAID, and also we can also give diclofenac with misoprostol, which is an NSAID plus a prostaglandin, and naproxen with esomeprazole, which is in NSAID plus a PPI po.
Alam mo dyan, these are all available in the States, but these are not available in the country, okay? Just for your information. We don't have this gastroprotective containing combination pills available in the
Yes,
country.
yes po, Doc. Yes po.
Now, let me just ask you one question. What do you understand by GI risk? And what do you understand by CV risk?
Uh, for those po taking aspirin, those with
What,
underlying
what is okay?
cardiovascular diseases like coronary heart disease and
Coronary
stroke po.
artery. Okay. How about GI risk?
For GI risk po, for those with history of peptic ulcer diseases po.
What else? Only history of peptic ulcer disease?
Jan, you have the slide previously,
Meron
the
pa
one
slide with
commented naman by Dr. Chan.
Dr. Chan, okay? Yun ang
Yun.
sinasabi ni Dr. Chan. That's why I
Speaking.
wanted to understand this.
Present.
Pakita mo, Jan. Yun yung may go back, I think 2 or 3 slides. Isa pa. Sige pa. Sige pa. Asa na?
Yeah.
Yan.
Yan. Yan.
Okay.
That's it. Okay?
So, naintindihan mo na?
Yes po, Doc.
Okay.
Ayun. Okay.
And additional information po, Doc.
Additional information. Sige.
Regarding po the drug interaction, since the patient po is taking clopidogrel, there is a possible drug interaction po with PPI, which is omeprazole po. Since omeprazole and
That's
clopidogrel are metabolized by the same cytochrome po, which is
But that is
CYP2C19 po.
wrong already. Marami ng
So,
data dyan. That's not
True. Okay, John. I think you're the last member of your group, but again, I'm waiting for what to do for patients with GI bleeding related to NSAID.
wala ka nun. It's not in your slide. Can we go back to the peptic ulcer disease?
Doc, it may
Yeah,
be
but you should have one statement. Why in NSAID gastropathy as the possible cause of the patient's upper GI bleeding? Ikaw na yung last speaker, di ba?
yes po, Doc.
Okay. So just one statement. Then we go to the PUD group. So Jan, the statement should run this way. Our group thinks that NSAID gastropathy is the possible cause of the patient's upper GI bleeding because
Our group will think that NSAID gastropathy may be the cause of the peptic ulcer disease po due to the advanced
not
age
the
of the
peptic ulcer
patient.
disease, the patient's upper GI bleeding. That's the
Upper
problem.
GI bleeding po.
Oh.
Maybe
Because
due to the risk factors po of the patient like advanced
No.
age,
Go to what is obvious, John. Go to what is obvious. Go to what is obvious.
What's
Ano
the
nasa
first
history?
What's the first reason to consider NSAID gastropathy?
Title mo yan eh.
the use po of high dose and NSAIDs and long-term use po of NSAIDs.
Okay. And then
And the
Bakit?
advanced age po of the patient.
The risk
And
factor for GI bleeding.
And the patient has risk factors.
Yes.
yes po, Doc.
Okay.
What are the risk factors present in the patient? Diyan, nakalagay
The
dyan.
risk factors present
Advanced
po in the patient is advanced age, and also po the presence of multi-system diseases like hypertension and diabetes.
And the
Okay.
patient is taking anticoagulants.
Yeah.
clopidogrel, di ba?
Yes po.
Ayan o, naka-bold na. Diba?
Bold, the bold.
Okay. So to
Okay.
answer the question of Dr. D earlier about GI bleeding, what to do if it is due to NSAID, I think can be answered by the previous group, which is the one dealing on peptic ulcer as the
Yeah,
cause of.
agree.
So is the peptic ulcer group ready? Christian Cosme.
Hello?
Yes, Christian, go ahead.
Yan. Yes, okay na.
Go ahead.
So, good morning, doctor. So, sorry for the technical difficulties a while ago. So, I'm Christian Cosme, and I'm here to present about peptic ulcer disease. So, it is defined as a disruption of the mucosal integrity of the stomach and or duodenum leading to a local defect or excavation due to active inflammation. So, it is defined as breaks in the mucosal surface which is greater than 5 millimeter in size, which extends to the mucosa. So it has two types, no, depending on the location, namely gastric ulcer and duodenal ulcer. So gastric ulcers can be malignant, so they should be biopsied upon discovery, while duodenal ulcers, which occurs more often in the first part of the duodenum, are usually benign. There are several risk factors or causes of peptic ulcers.
Christian, are you still there?
What's happening? Dr. Romano, what's happening?
I don't think he is in the session, Doctora. I can
Huh?
see his name. Paulo Dino,
No
nawala nga
longer
po.
with us. Kakatakot yan.
Wag naman ganon. I think he got disconnected. And probably we can, uh, if the FASIs will agree, I think we can spend some time on this. Since this has an overlap in the SGD, maybe we can spend some more time on this during the SGD. This
Yeah.
specific.
Maybe go ahead with the second speaker.
Yes. Okay, so I'll move the
Si John na,
slides.
John Francis.
Okay.
Dr. Chan, maybe you can ask John later in your SGD. Is there a problem in his connection or I don't know.
Okay, so in order to get an accurate diagnosis of the disease, thorough medical history must be obtained since the patient may have acquired an H. pylori infection, medicated with an NSAID, or has a history of smoking. The most common presentation of peptic ulcer disease is, of course, abdominal pain in the epigastric region, characterized as burning or gnawing discomfort, which may also be described as an ill-defined aching sensation or as hunger. So the typical pain pattern in duodenal ulcer occurs 90 minutes to 3 hours after a meal and is frequently relieved by antacids or food. And the pain that awakens the patient from sleep is the most discriminating symptom. And it usually happens between 12 midnight to 3 a.m. And this symptom occurs in two-thirds of patients with duodenal ulcer and one-third in non-ulcer dyspepsia. On the other hand, the pain pattern in gastric ulcer is different from that in duodenal ulcer patients, where the discomfort may be precipitated by food. Also, nausea and weight loss occur more commonly in gastric ulcer patients. So, variation in the intensity or distribution of the abdominal pain, as well as the onset of associated symptoms such as nausea and vomiting, may be indicative of an ulcer complication. Dyspepsia that becomes constant, no longer relieved by food or antacids, or radiates to the back may indicate a penetrating ulcer, usually to the pancreas. Sudden onset of severe generalized abdominal pain may indicate perforation. Pain worsening with meals, nausea, and vomiting of the undigested food suggests gastric outlet obstruction. And tarry stools or coffee ground emesis indicate bleeding. So, epigastric tenderness is the most frequent finding in patients with peptic ulcer disease. And the pain may be found to the right of the midline in 20% of patients. However, this is still unreliable, so other pertinent PE findings must also be considered. Tachycardia and orthostasis suggest dehydration secondary to vomiting or active GI blood loss. A severely tender, board-like abdomen suggests a perforation, and the presence of a succussion splash indicates retained fluid in the stomach, which suggests gastric outlet obstruction.
John?
Yes, Doc.
Yeah, although I appreciate you differentiating duodenal from gastric ulcer, but these are not absolute. You can have patients complaining of this symptom and then only to find out they have the other ulcer. So just remember it is actually not absolute. Okay.
Yes, Doc.
Yes, Silone?
Good morning, doctors. Similarly to your NSAID gastropathy, to diagnose your peptic ulcer disease, we can also do your. There must be a documentation of your ulcer. So it was presented earlier that we can either do endoscopy or barium study. However, for practicality and specificity, we would opt to do of your endoscopy because barium study in case of an emergency setting, such as in our patient presenting with upper GA bleeding, it is more practical to do an endoscopy because of the following advantages: the direct visualization of the mucosa, the photographic documentation. The photographic documentation is very much important so that in this is important in the management of the patient so that in future endoscopy of the patient can check if the ulcer has been fully treated or not. And to rule out or rule in the possible malignancies and H. pylori, we must do a tissue biopsy. So in the following slide, these are just your pictures of endoscopy findings. Here on your left would be the duodenal ulcers. Here on your ulcers. This one is a gastric ulcer. It has a well-demarcated margin, a white base, smooth base. However, for a more malignant gastric cancer, as you can see here, there are nodularities. And usually for a benign cancer, it would be a punched-in lesion. However, for gastric cancer, it would be everted, and it has a more dirty looking appearance compared to that of your benign looking gastric ulcer. So for the diagnosis of your Helicobacter pylori, since the patient is already, we're doing an endoscopy for this patient, we can do a rapid urease test, which goes hand in hand with your endoscopy finding. The most commonly test done would be your
Okay,
giant
Cylon,
ulcer would
you don't
be,
need to go into
yes,
the
doctor.
details of this because we will be discussing that in detail in the SGD. So you have to focus your discussion on PUD with upper GI bleeding.
Okay po, doctor. Just to answer the question of Dr. Velasco po, a giant ulcer would have a size of 3 centimeters to about 6 centimeters. So for the barium study, just to mention, this is a rarely used first test in documenting ulcer. However, for the case of upper GA bleeding, just the to notice would be the endoscopy find.
Okay, Cylon. Cylon? Hello? Hello, Cylon?
You hear me po?
Yeah, can you hear me? Hello?
Hello?
Can you hear me?
Hello po, doctor.
Okay.
Yes po, yes po.
You mentioned that endoscopy is the choice. You mentioned reasons. Can you
Yes po, doctor.
repeat that? Because I didn't hear you say a very important indication for endoscopy in patients with upper GI bleeding. You
So if patient she
emphasize
presents with,
on photographic documentation, no? That's what you emphasized a while ago. So what would be a more important indication of endoscopy in patients with upper GI bleeding? See, it's not there in your
okay.
slide.
So indications po to do your endoscopic feeding would be, since the patient is presenting with coffee ground melena, we would like to see if there is any possible complications in the bleeding of the patient. If there is
What complication? Complicated na nga yung ulcer eh. There's already bleeding. So what is a more important indication for endoscopy? What can endoscopy do aside from confirming that there is an ulcer and that there is bleeding from that ulcer?
it can also be a source of therapeutic management.
There, okay? That's the more important one, which you cannot do by doing your barium study.
Yes po,
All
doctor.
right. Oh, and the barium study will not tell you whether, yes, it can identify the ulcer, can identify whether it's gastric or duodenal, but it cannot tell you which one is bleeding. All right. And you cannot categorize the activity of bleeding in that ulcer. It's only through endoscopy. And then, if therapy is indicated right there during endoscopic procedure, therapeutic intervention can be instituted. So that's the reason for the use or the indication of endoscopy in patients with upper GI bleeding.
Okay po. Thank you po, Doctor.
Good morning po, doctor. So for the therapeutic goals, the first is we provide symptom relief, promote ulcer healing, prevent recurrence and development of complications, and eradicate H. pylori. So for the drugs used in the treatment of peptic ulcer disease, there are two groups. The first one is the acid suppressing drugs, and the second is the mucosal protective agents. So for the acid
Okay,
suppressing drugs,
Cristel,
yes, doc.
can I cut you there? Can you go back to your first slide?
Okay po, doc.
All right. For this particular patient, we're not talking of peptic ulcer in general. For this particular patient, what symptom do you want relieved for this patient? Let's focus. Are you still there, Cristel?
Yes po, doc.
Oh,
What is the
anybody
present-
from the group can answer.
Cristel, what is the presentation of the patient?
Hypotensive po yung patient po. Then there's vomiting.
What is it due to? Your hypertension.
Vomiting of what?
What is our topic for this morning?
Hello?
Yes, Cristel.
Yes.
The patient is hypotensive po due to fluid loss dahil po nung vomiting. And secondary din po kasi po there is bleeding po due to the ulcer.
So, ang topic natin this morning is upper GI bleeding.
Upper
Okay?
GI bleeding.
So, what will be the focus of our treatment for a patient with peptic ulcer disease presenting with upper GI bleeding? Yun yung goal mo, di ba?
Apo.
So, while this is the general goals for a patient with peptic ulcer disease, we are now talking about the development of complication of peptic ulcer disease, which in this case is upper GI bleeding. Okay? So, how are we going to
Yes po, doc.
treat that?
We have to ensure.
Kasi later in the SGD, peptic ulcer disease in details. But right now, what we're focusing on is GI bleeding as a complication of peptic ulcer disease. And how are we going to treat that?
So first po is we have to stop the bleeding po. Then we have to ensure po na stable po yung vital signs ng patient so we can give the patient if ever po maging unstable siya with IV crystalloid po.
So wala kang slide noon.
Wala po.
So ang treatment mo is for peptic ulcer in general. That's why you have these acid suppressing agents.
Yes po, doc. And for eradication po of H. pylori if ever present po.
Pylori, okay. Anything else after this?
Surgical therapy po.
Wala kang endoscopic therapy?
Wala po.
Dr. Romano, what are we doing? What are we going to do?
Can
Albert, maybe you should help the students and tell them what endoscopic treatments can be done, because this was supposed to be your lecture at the PSG.
Okay. Well, it was postponed. It was postponed because of COVID-19. Well, anyway, because Christelle do not have that slide, I think what is the next? Uh, who's the next presenter? Surgical therapy. Okay. So wala talaga. Okay. Okay.
Dr. Ismael,
Yes.
maybe we can go back to the first presenter. I think Kimberly Rose did show something about what to do. I was mentioning it being very specific, the approach, or
Okay.
probably
Okay. We're going back to that slide. Can we go back to the first?
to the slide of John Corpus.
Okay. Back some more. Okay. Okay. That's right. This one. Okay. Is everybody on board? Are you all listening to me?
Yes, we are. We are.
Okay.
Okay,
You,
okay.
okay. You
Okay.
see, first in this column, in this first endoscopic features, this is in reference to what type of ulcer there is in the patient. The endoscopic features is actually classified into forest classification. Forest 1, meaning active bleeding. It is divided into 1A and 1B. 1A means there is spurting bleeding. 1B means there's oozing. Okay. Now, forest 2 means that there are stigmata of recent hemorrhage. Uh, Forest 1A, there is a visible vessel. B, you have a forest 2B, means that there is a clot covering the uh, ulcer. And forest 2C, there is a black pigmented spot, which is flat. Okay. And the last forest classification is forest 3. There is a clean-based ulcer. Now, the appearance of these ulcers will tell you whether you need to do endoscopic treatment. So for forest 1, whether A or B, they are actively bleeding ulcers, needs therapeutic intervention. If you have a visible vessel or a clot, again, you need to do therapeutic endoscopic intervention. But for flat pigmented spot or clean-based ulcer, there is no need to do endoscopic therapy. Now, the third line in this algorithm is the need for PPI. Again, because active bleeding ulcers forest 1A, 1B, and 2A and 2B, Who changed the slide? Okay. Means that you need to give intensive PPI therapy. And what do we mean by intensive PPI therapy? That means an 80 milligram of omeprazole or its equivalent in esomeprazole, pantoprazole, rabeprazole, etc. And you need to give this as an IV bolus of 80 milligram and then followed by a drip of 8 milligram uh, per uh, per hour
Hour.
per hour. Okay, and because they need to be given for at least 72 hours or 3 days because they have found out that patients with upper GI bleeding with this kind of uh, lesions, they tend to recur. They tend to recur within 72 hours or 3 days. And therefore, you need to give this intensive PPI therapy for at least 3 days. And the recent guideline after this, the recent guideline tells us that after giving the 3-day intensive PPI therapy, you need to give a double dose of the PPI, in this case 40 milligram, for example, of esomeprazole twice a day rather than once a day. And that will be continued for 4 to 6 weeks if it is duodenal ulcer, 6 to 8 weeks if it is due to gastric ulcer. Is that okay, Dr. Chan?
Thank you very much, Dr. Ismail, for that
Very
expert lecture and opinion.
Dr. Ismail, you have 100 for my grade, for your grade.
Oh, thank you.
101 from me.
Okay, let's proceed to the gastric cancer.
Wait, hold up.
I will scroll to the gastric cancer slides. That hold on. Okay.
Good morning, doctors. So for gastric cancer, there's um, 85% accounts for adenocarcinoma and 15% accounts for lymphomas, gastrointestinal tumors, and leiomyosarcomas. So for adenocarcinoma, dysplasia is the universal precursor to gastric adenocarcinoma. In the most lower photomicrograph, we can see that there's increased cell proliferation of normal cell size, which accounts for dysplasia. So it has two types, histological types, which is diffuse type and intestinal type. So in the United States, it's mainly in the proximal stomach. Then for the Philippines, according to a journal, it's more on the non-cardia portion. So for the intestinal type, it's termed intestinal because there's the formation of gland-like tubular structure. As we can see on the photomicrograph above, there's the formation of gland-like structures. Then there's also grossly, it grows along broad cohesive fronts to form either an exophytic mass or an ulcerated tumor. It's most commonly seen in the antrum and the lesser curvature. So as we can see on the lower picture here, it's a gross picture showing an elevated mass with heaped up borders and ulcerated a central ulceration. Then it's the type of cancer most commonly linked to the environment and dietary risk factors. So it's more predominant in the high incidence region of gastric cancer, and it's postulated as a multi-step model, wherein there's a pre-neoplastic change that leads to the development of gastric cancer.
So the most common pre-neoplastic change is atrophic gastritis, and the most commonly involved organism is Helicobacter pylori. So there has been an genomic profiling done for gastric adenocarcinoma. So there are four groups. So chromosomally unstable, genomically stable, microsatellite unstable tumors, and EBV positive tumors. So the intestinal type accounts for 50% of the chromosomally unstable tumors. So the diffuse type of gastric adenocarcinoma lacks the glandular structures as compared to the intestinal type, and it consists of poorly cohesive cells that infiltrate the walls of the stomach. So it has a signet cell morphology, as we can see on the photomicrograph on the upper right, which are the discohesive cells with large mucin vacuoles. So it pushes the nucleus to the side, hence the signet ring morphology. So it occurs at a younger age and has the defective intracellular adhesion because of the loss of E-cadherin. So this presents with a worse prognosis, and linitis plastica, or the leather bottle-like stomach, can occur. So what happens is there is extensive involvement of the stomach. As we can see in the gross picture above, the stomach has become thickened and there's the loss of the rugal folds. So the diffuse type accounts for the 20% of the genomically stable tumors. So for the epidemiology, it's the third most frequent cause of cancer-related death worldwide, and in 2018 it ranks as the fifth in the number of new cases. So it's high in disparate regions such as Japan, China, Chile, Ireland. So as we can see in the bar graph above, um, the blue one represents the incidence and the red one represents the mortality rate in 2018 WHO Global Cancer Observatory. So it's highest in Eastern Asia, Central Europe, and Southern America. And also, it's greater among lower socioeconomical bracket. However, in the 2018 data, it's now more prevalent in the upper middle class and high income communities. So migrants from high to low incidence nation maintain the susceptibility. However, their children retains that of the new country they're in. So it can be explained by early environmental exposure related to the development of gastric cancer, with dietary carcinogens considered as the most likely factor. So for the Philippines, our incidence of gastric cancer decreased from 1980 to 2007, with an annual change of minus 2.5% in males and minus 2.3% in females, which may be partly attributable to the changes in food preservation, such as refrigeration instead of salting or smoking the food. So the national incidence increases steeply by 50 among males and 55 among females. The national incidence rate is 3.8 per 100,000, and the mortality rate is 3.4 per 100,000, and the relative five-year survival is 27.3%. So in the 2018 data, it ranks number 14 in the new cases of cancer and 11 in the cancer-related death. Thank you.
Okay, so let's now discuss the risk factors for gastric carcinoma. So it was mentioned earlier that carcinoma is sequential in nature. So in the figure on the right, you can see how the risk factors affects the sequence. Also, it was mentioned that the H. pylori infection is recognized as the primary etiologic agent for gastric carcinoma. It is actually considered class 1 carcinogen by the International Agency for Research on Cancer. It actually increases the risk for gastric CA by up to 6 times higher than a non-infected person. And it also causes a chronic type of inflammation that may lead to atrophic gastritis, which was mentioned earlier to be one of the primary causes of um, gastric cancer, as the usual gastric mucosa is replaced by the intestinal type cells, which eventually leads to atypia and neoplasia. Ingestion of high concentrations of are nitrates that are found in dried, smoke, and salted foods are associated with a higher risk, as well as ingestion of partially decayed foods, which is an exogenous source of nitrate converting bacteria, which is also prevalent in the lower socioeconomic class. That's why they are also considered a risk factor group. Next, for the genetic factors, approximately 10 to 15% of adenocarcinomas in the proximal stomach, gastroesophageal junction, and distal esophagus show overexpression of the HER2 new gene. And a germline mutation in the E-cadherin gene, as mentioned earlier, are linked to the diffuse type of gastric carcinoma. Familial adenomatous polyposis, especially if with fundic gland polyposis, are shown to have an increased risk, as well as those patients with a first-degree family history of gastric carcinoma. Surveillance and screening for cancer are recommended for these patients. Also, it has been shown that individuals with blood group A have a higher incidence of gastric carcinoma compared to blood group O, which may be related to difference in mucus secretion and altered mucosal protection. Also, cigarette smoking, which is an already established carcinogen, has been linked to higher incidence of gastric carcinoma. Let's now go to the clinical features. So, early on in gastric carcinoma, it is usually asymptomatic. Up to 80% of the cases are asymptomatic in the early stages. Weight loss is the most prevalent clinical feature, which is about 60% of the cases, as well as the abdominal discomfort. The ones highlighted in both are the ones that our patient also has. Metastasis in gastric carcinoma occur frequently, as gastric CA is metastatic in diagnosis 33% of the time. It may occur through the lymphatics, through the direct extension, or hematogenously. So these are the examples of frequent signs of metastasis in gastric CA. The metastasis to the left supraclavicular sentinel nodes, or the Virchow's node, to the periumbilical lymph nodes, or the Sister Mary Joseph node. It can also metastasize to the pouch of Douglas, which is possible through the DRE, which is also called the Bloomer shelf. And it can also metastasize to the ovaries, which is called the Krukenberg's ovarian tumor. Although rare and unusual, paraneoplastic syndromes can occur with gastric CA, and there are reports of migratory thrombophlebitis, hyperpigmentation in the axilla or acanthosis nigricans, and sudden onset of diffuse seborrheic keratosis, or the so-called lesser Trelat sign. So these are the clinical features of the gastric CA.
Good morning, doctors. I am Anjali L. Cuyugan, and I will be presenting the diagnosis and staging of gastric cancer. So the procedure of choice for gastric cancer diagnosis is EGD, or esophagogastroduodenoscopy. So according to the American Gastroenterological Association, or AGA, EGD is indicated for patients who are more than 55 years old with new onset dyspepsia, or patients less than 55 years old with alarm symptoms such as weight loss, recurrent vomiting, dysphagia, evidence of bleeding, or anemia, or in patients who are dyspeptic without relief of symptoms after empiric trial of PPIs or eradication of H. pylori. It is recommended to have 6 to 8 biopsy specimens from the edge and base of a non-healing ulcer. It has been found that lesions with distinct irregular mucosal surface and vascular patterns are correlated with dysplasia and carcinoma. Another diagnostic test is barium studies, but it has been largely replaced by upper GI endoscopy. So next is endoscopic ultrasonography, or EUS. This is the test of choice for assessing tumor depth and nodal involvement. Therefore, it is the best studied modality for the staging of gastric cancer. This allows visualization of the 5 layers of the gastric walls, namely the mucosa, uh, superficial mucosa as the innermost, followed by the deep mucosa, submucosa, muscularis propria, and then the outermost, which is the serosa. This is also able to identify and perform biopsies such as a final aspiration of submucosal lesions, since gastric ulcers identified at the time of such endoscopic procedure may appear benign but merit biopsy in order to exclude a malignancy. Endoscopic biopsies should be made as deeply as possible due to the submucosal location of lymphoid tumors because gastric carcinomas are difficult to distinguish clinically or endoscopically from gastric lymphomas. So in the table on your left, it shows the EUS appearance of the 5 layers of the gastric wall. So hyperechoic means it appears white, and then hypoechoic means that it appears black. So on the image on your right, topmost, the innermost is M, which is the superficial mucosa, followed by the muscularis mucosa, then by the submucosa, and then by the muscularis propria, and the outermost, which is the serosa. And on the figure B, or the image on your lower right, it shows a hyperechoic mucosal mass, which appears hyperechoic. EUS also has a sensitivity of 86% and a specificity of 91%. So here we can see the instrument used in EUS. In the picture on your left, it shows that the EUS instrument is equipped with an echo endoscope and an ultrasound transducer, which facilitate visualization and imaging. Well, the image on your right shows ultrasound-guided fine needle aspiration. So the instrument includes a fine needle to facilitate biopsy, in addition to the 2 parts mentioned before, which are the echo endoscope and the ultrasound transducer. So other modalities for diagnosis and staging are the following, although these are not routinely used. So these are CT scan, which is mostly used for detecting distant metastasis, and as complement to EUS. This shows the 3 distinct layers only compared to the EUS, which shows the 5 layers. So the 3 distinct layers are the mucosa, submucosa, and the muscular serosa. Next is a PET scan or positron emission tomography. These are not recommended as sole imaging test, but rather used as an adjunct because most gastric adenocarcinomas show low uptake of fluorodeoxyglucose. MRI with gadolinium has also been used for gastric cancer staging and is similar to CT in advantages. CT gastropathy is being studied for diagnosis and early detection of gastric cancer, so it is not yet recommended for screening outside of the research setting. Then lastly, serum markers such as
Nawala ang slides.
Yes, Ome, what happened?
Someone must have pressed the stop. I'm going to reload it again.
No slide, no audio.
Ome, when you say somebody has pressed the stop, are these the students or the moderators?
Anyone from the moderators or the presenters can stop the presentation.
I see.
Probably si Mr. Dr. Chan ang nag-stop na.
Wala, di ko nga ginagalaw.
Continue, Anjali.
okay po. Serum markers serum carcinoembryonic antigen or CEA and carbohydrate antigen have been frequently elevated in recurrent gastric cancer. However, there is still no reliable serum markers that have been identified with high sensitivity and specificity for gastric cancer. So lastly, this is the staging of gastric cancer. So staging gastric cancer is important so as to help predict the prognosis of the patient. So first, the most common staging for gastric cancer is the TNM system. So the T stands for the depth and of penetration of the tumor. So let's focus on the image on your upper left. So the T is divided into early and advanced lesions. Early gastric cancer or T1 does not invade beyond the submucosa. So as you can see here, the invasion is only up to the submucosa. While advanced gastric cancer such as T2 to T4 involves the submucosa. So for T2, it invades up to the muscularis propria, T3 up to the serosa, and T4 up to the adjacent organ. It is important to note that this division disregards whether there is lymph node involvement or not. Well, for the nodal involvement, or N0 stands for no lymph node involvement, N1, 1 to 2 lymph nodes, N2, 3 to 6 lymph nodes, and N3, 7 or more lymph nodes. While M or metastasis, um, M0 is for no metastasis, and M1 is for presence of distant metastasis. Once we have the TNM scores, we can now do the staging, which is in the you can refer in the table on your right. So once you have the TNM score, you can now correlate it with its particular or specific stage. In the rightmost column, you can see that as the stage progresses, the 5-year survival also decreases. So like in stage 0, the 5-year survival is 90%, while for stage 4, the 5-year survival is 3%. So malignant gastric ulcers must be recognized before they penetrate into surrounding tissues because the rate of cure of early lesions limited to the mucosa or submucosa is greater than 80%.
Good morning, doctors. I am Jesserin Dagkutan, and I'm here to discuss the treatments of gastric carcinoma. So, for the goals of treatment, first is for the curative outcome of the gastric carcinoma. Second is to prevent the possible complications of gastric carcinoma, which is related to the disease progression, such as uh, pain, weight loss, difficulty swallowing, nausea, vomiting, and in the case of our patient, the upper GI bleeding. And last is for the palliation of symptoms. Next. So for the surgical treatment, it's the primary curative treatment of gastric carcinoma. And it's often the most effective in the palliation of symptoms, specifically for symptoms of obstruction. And it's also useful for staging of gastric cancer together with laparoscopy. Uh, so the following are the surgical procedures that you can do. First, complete surgical removal of the tumor with resection of the adjacent lymph nodes. And second, for second subtotal gastrectomy. Uh, uh, an image on your right side can be seen wherein it shows which structures of of the stomach will be resected and And then lastly, we can also do total or near total gastrectomy. You can see the image on the right side, lower right, of which structures will be resected in total or near total gastrectomy. Also, additional info for subtotal gastrectomy, it's the treatment of choice for patients with distal carcinoma. And for the total or near total gastrectomy, it's usually required for proximal tumors and patients with diffuse gastric cancer. Surgical management also aids in the diagnosis of non-healing gastric ulcers with negative biopsy results and patients who present with persistent pyloric outlet obstruction, which will suggest an antral carcinoma. So yeah. So basically, the resection of the tumor bulk is the best form of palliation, and it can also enhance the probability of benefit to the subsequent therapy. So next, for the radiation therapy, gastric adenocarcinoma is relatively radiodistant. radio resistant. Sorry. So it's hard to get an adequate control of the primary tumor since the required doses of the external beam irradiation may exceed the tolerance of the surrounding structures. And the major role of radiation therapy has been for palliation of pain. However, used alone, it cannot prolong survival, and it's usually uh, and the patient has better prognosis if treated with 5-fluorouracil, which is a radiosensitizer, plus leucovorin combined with the radiation therapy. So for the chemotherapy, gastric carcinomas are usually fairly resistant to conventional chemotherapy. So it's usually used as a component of combination treatment. So the following drugs are the following are the drugs usually used in the in chemotherapy, chemotherapy of gastric carcinoma. So next. Okay. So for the combination therapy, we could do adjuvant chemotherapy after curative resection of the tumor. Next is the chemoradiation. We can opt to do preoperative chemoradiation, and next is perioperative chemotherapy, neoadjuvant chemotherapy, postoperative hyperthermic intraperitoneal chemotherapy, or a combination chemotherapy, pre-op and perioperative plus postoperative chemoradiation for the combination therapy. For the postoperative hyperthermic intraperitoneal chemotherapy, uh, uh, usually systemic chemotherapy is ineffective for peritoneal metastasis. Thus, we can consider intraperitoneal chemotherapy in these patients because the tumors which are resected for cure. However, it can have a higher likelihood of microscopic residual diseases. So we can consider the intraperitoneal chemotherapy. So next is for unresectable diseases. We can do chemotherapy first for locally advanced cancer without distant metastasis. Second is for multi-drug cisplatin-based regimen, and third is a docetaxel or irinotecan monotherapy. We can also do surgical gastrojejunostomy or duodenal stenting. For the prognosis, the following complete surgical resection the following depends on the degree of tumor penetration into the stomach wall, and it will have an adverse effect on the prognosis if there is regional lymph node involvement or vascular invasion. So the probability of survival after 5 years is 25 to 30% for patients who are able to undergo complete resection, and 20% for those with distal tumor, and less than 10% for those with proximal tumors. There is also a chance of recurrence continuing for at least 8 years after surgery, and the median survival time is less than 12 months. Thank you.
Finally, this is a tabulation of the salient findings of our patient along with the signs and symptoms and risk factors present in the three differential diagnoses. So while the patient is of advanced age, has vague abdominal discomfort, and presents with weight loss, we can rule out gastric carcinoma as our diagnosis since other pertinent associated findings such as lymphatic spread um, were absent on our patient, and the signs and symptoms presented by our patient were of acute onset. The final diagnosis of our patient is upper GI bleeding secondary to peptic ulcer disease. Based on the clinical findings of the patient, it is important to take note, however, that the patient may have concomitant NSAID-induced gastropathy due to the 5-year intermittent use of NSAIDs by the patient, which may complicate his PUD. Endoscopy is warranted so that we can further establish the diagnosis. Thank you.
Okay. Are we going to proceed with the second BGD?
We should.
We're actually running out of time.